I wanted to come and talk to you about my experience in managing chronic pain patients. I originally actually trained as an electronics engineer, and then my first medical or clinical health science training was actually as a chiropractic physician. So I learned some things in that training that were valuable, some things that were wrong, that I came to understand later once I was in practice. And then I was informed by that once I went to medical school and studied more what we call functional or integrative medicine. So I'm going to give you a little bit of a perspective from a functional medicine doctor on how we deal with chronic pain syndromes. And I will say, first of all, I'm not a specialist in chronic regional pain syndrome per se. I'm not trained specifically as a pain management doctor, but I bring a different kind of lens, I think, to these kind of complex chronic pain patients, perhaps from my combined experience, not only clinically, but academically. If you ask most doctors, what do you think of if your medical assistant or your front desk tells you that you have a patient down the hall in a treatment room and they think they have chronic regional pain syndrome or they have fibromyalgia? Well, most doctors, if they're honest with you, will say that this is their reaction right there, okay? And I tell doctors that this is your reaction when you're sitting in the room because you're both usually frustrated with one another, right? You've had experiences along the line that have frustrated both of you. And it doesn't have to be like that if you take a different tact and you take a different approach to these patients. I'm sure many of you in this room, if you suffer from chronic pain, a chronic pain syndrome of any kind, have been frustrated and let down by the medical establishment and feel like you've not always been treated in the best way, or that you're treated as if you had a serious condition or a real condition. Sometimes you're doubted in your sincerity, and it shouldn't be that way. Too often, and my experience honestly is more with global pain patients or patients with the diagnosis of fibromyalgia, when many of them have been really dismissed. It's changed a lot, it's improved a lot, but if I go, I've been practicing 25 years, and certainly if I go back a couple of decades, many patients were just, told that it's all in their head and they're making it all up and they need to get back with life, and basically made to feel like they were crazy. And when you think about it, many of them are routed to mental health care professionals, which may be the right thing to do, but I don't think it's the right thing to do if the only solution then is to give psychotropic medications or some other medications that are used commonly in psychiatry, originally as an off-label use and now actually as an approved use. In functional or integrative medicine, we really try to always back up and remember that we need to deal with patients as individuals. What's different about functional medicine than conventional medicine? Well, a lot of it's the same. We're all based on the same, biochemistry and physiology and differential diagnosis, and we certainly understand the importance of disease categories and diagnoses and standards of care and treatment. But in functional medicine, we're not as hung up by people's labels. We don't look at you as a chronic regional pain entity or a fibromyalgia entity or whatever else your label or your diagnosis is. We try to approach you as an individual with your own unique metabolism, biochemistry, your own different things that you bring to your experience. We call them triggers, antecedents, and mediators. The things that may have triggered it, the things that have gone before in maybe your experience or even your parents' experience or your experience in very early life and how that informs your disorder now. Because these pain syndromes, and particularly global pain syndromes like fibromyalgia, are central sensitivity syndromes. And what does that mean? It means that much of this is mediated centrally in the brain, right, deep in the brain. And so all those years back when physicians were telling these patients, it's all in your head, they were right. But that's not what they meant when they said that, right? But in the end, they may be right, and we'll look at how that may be true. So central sensitivity syndromes bring in much more than pain. as many of the fine speakers before me talked about, you have a lot of other issues. You know, there's anxiety, there's depression, there's irritable bowel, there's irritable everything, right? There's migraine, there's Raynaud's phenomena. There's all these things that are this constellation of symptoms and problems that appear in these disorders. And there's a lot of overlap and overlay between a lot of the disorders in this camp. And certainly regional pain syndromes are represented there, but also something like fibromyalgia, also something like chronic fatigue syndrome. Various other psychiatric disorders are linked in there, and others. And what complicates this is these disorders are a bit fuzzy around the edges for the classic medical diagnostic paradigm, right? Because when you go to medical school, it's like a very expensive 4-year experience of Trivial Pursuit, right? It's basically like if a patient comes in and these elements are in their story when you talk to them, and this test and this test and this test are positive, or these imaging findings are the way they are, then it equals disease X, right? And if they have disease X, then the appropriate standard of care treatment is treatment Y, right? So it's all about connecting these dots, but that's a very reductionist discrete methodology, right? And in chronic complex disease, it doesn't work well when you look at people like that, right? You have to look at them in a different way. And what complicates this for many healthcare providers, not just physicians, but providers of all types, is that there's no chronic regional pain syndrome test on that you can check on a lab form. And there's no fibromyalgia factor test that you can go down the quest and get your lab drawn and it says yes or no, you have it. There's no binary referendum on it like that. So it's really, to a large degree, a clinical diagnosis. There's some changes in that happening now. But if you look at the medical literature, it's clear, and I'm using the case of fibromyalgia here, not chronic regional pain syndrome, but in fibromyalgia, where there is a published diagnostic criteria that's evolved through the last 20 or so years, most physicians are very ill-informed about the diagnostic criteria. They don't know how to follow it. The criteria has its limitations as well. But when they actually study it, when doctors diagnose fibromyalgia, primary care doctors, even there were some rheumatologists in this, internal medicine doctors in this whole cohort of physicians diagnosing fibromyalgia patients. When these patients were then sent on referral to a group of rheumatology specialists in fibromyalgia, highly trained in it, the diagnosis was correct 34% of the time, which means that 66% of the time they got it wrong, which means they would have been better to flip a coin. Right? That's not very assuring. So we need to do a better job at that. And this kind of result has been replicated in many studies. So when you're looking at these different chronic pain syndromes, something like fibromyalgia or global pain syndrome, the laser pointer's fading out a little bit here, you'll see that what you have is global pain. This is pain everywhere around the body. It doesn't discriminate on the area of anatomy. You have pain above the waist, below the waist, left side, right side, along the midline, out in the periphery, or out in the extremities. Where in more of a regional pain syndrome, it's confined more anatomically. So they do differ in that respect, but there's still a lot of commonality that I want to bring some of the lessons from my work in mainly global pain or fibromyalgia patients. And I just wanted to start with just a little review. I don't want to have neuroanatomy class here, but if you have a muscle in the body, let's say, and someone sticks a pin in it, how do you know that someone stuck a pin in it? Well, you have pain, right? Well, how do you have pain? Well, you have a nociceptive receptor there that senses that, that pin got stuck in the muscle, and it depolarizes a nerve, and it transmits a signal back to the spinal cord at the specific level that is responsible, or what we call innervates that muscle or that level. And right there, there's an exchange of information right here. It's called the dorsal horn of the spinal cord. And then it crosses the midline of the body and it goes up toward your brain. It's in what we call an ascending tract, and it's the spinal thalamic tract. That's because it stops at the thalamus, a part of your brain, and then it goes up to the cortex, and it goes up to an area of your higher brain that you know exactly where that pin went in your muscle. so that you don't even have to think about it. If someone sticks a pin in your calf from behind you and sneaks up on you, before you even think about it, you're going like that, right? Your brain knows exactly where it is. Now, not only does it send it up to the brain so you can localize it, but there's some side pathways too. There's a spinal reticular tract and there's a spinal mesencephalic tract, and we're going to talk about this just in a second so I can make my point. Now, some of the medications that are now approved for fibromyalgia or global pain syndromes, things like SSNRI, selective serotonin norepinephrine reuptake inhibitors, and the use of tricyclics. These are two different classes of antidepressant drugs. They're antidepressants. They were developed as such. They were never really developed from the ground floor up for chronic pain or for fibromyalgia. They were used for a long time in an off-label use, and now they've been renamed, reborn as fibromyalgia drugs. Well, they act centrally in the brain, but they also act locally right here where this first information exchange occurs to sort of down-regulate the circuit. It makes it harder for that information to pass through. The other class of drugs that are used commonly, the alpha-2 delta ligands, are basically anti-epileptic drugs when that's how they were developed, but they're used now for fibromyalgia, and it's one of the classes of drugs that's approved. It works centrally, but it also works on this original pathway that propagates the pain. So they do have some use, and for some patients they're very effective, but in a fairly large analysis by RAND in fibromyalgia, it showed that less than 25% of patients that are given these agents with a correct diagnosis of fibromyalgia get statistically significant benefit. And the ones that do usually have a decaying of that benefit over the course of several months after they start on it. So while they can be helpful, they're certainly not the answer. All right, we need to have more comprehensive solutions. And when you look at the spinal cord, in medical school, we learn it often like a wiring diagram, like we're electricians, right? And there's circuits, but it's really much more complex than that. Your spinal cord is actually a little mini brain. It has white matter, it has gray matter. It can actually learn from the pain experience, and it could modify how you interact with that pain experience. And this is a bit of a simplified version of what happens, but let's go back to that example where I stuck a pin in the muscle. This black neuron here is what I showed you before, where the pain signal comes in, it transfers, and it goes up to your brain so you know it came from this muscle. But if that stimulus, that pain stimulus, whatever's causing it, is either intense enough or it is persistent enough, it becomes chronic, right? It doesn't go away. Then you get also an activation of what are called secondary or association neurons, shown in red. These ones, when these pathways light up, there's the exchange of information. Again, it goes to your brain, but now it tells you that the original pain stimulus came from not only where the pin went in, but other structures, because these association pathways share a common pathway. So you no longer to discriminate that's where the pain is. It's actually spreading in your perception to other areas, okay? This is how referred pain happens in like myofascial trigger points. But I'll make it simpler for you. Physicians will certainly relate to this, but you will probably in your experience. If you have an injury, let's say you hurt your shoulder throwing a ball. If someone asks you that day or the next day, where do you hurt? You can often go, right here, all right? But if you don't get it treated, it becomes sort of a chronic nagging injury. If you ask that person 6 months later or a year later, where do you hurt? They don't go right here. They tend to go, I don't know, the whole thing just aches, right? That's this widening of what we call the receptive fields of pain. And this is how you get a spreading of pain, whether it's regional or if it, in the case of fibromyalgia, can actually become global. And we know some of the chemical messengers or mediators of this. One is an interesting neuropeptide called substance P. Substance P, it's a peptide, so it's protein in nature, but it mediates pain. More substance P in the central nervous system, in the cerebral spinal fluid, bathing your spinal cord, allows these secondary association pathways to be more facilitated. They're more likely to turn on, which means there's more likely that you're going to have a spreading of pain and a higher perception of a stimulus as something that's painful. Now, as is usually the case, there's something that counteracts this, and it's called the descending antinociceptive system. So this is my last neuro diagram with you, I promise. But let's go back and stick the pin in the muscle again down here. It just doesn't have a muscle on this diagram. The stimulus comes in, crosses the cord, goes up, and then goes to the thalamus and then to your brain, telling you exactly where that noxious stimulus occurred, in this case the pin going into your muscle. We said that it goes to the thalamus and then to the upper centers of the brain, but it also, this side pathway, the mesencephalon, this delivers the stimulus to an area in your brainstem. And this is in the mesencephalon. This is called the paraaqueductal gray. And then you have a downward stimulus that goes back down to where it came from originally. It stops over in the medulla, part of your brainstem, in an area specifically called the nucleus raphe magnus. And then finally back down to the exact segmental level where that stimulus first came in. And this downregulates. This shuts it off, basically. So it comes in, it lets you know, and then this kind of shuts everything down. Why is this kind of system necessary? Because if we didn't have that kind of system, our existence would be quite a miserable one. If you think about it, you took a shower this morning, right? And you get out of the shower, you realize, I have no clothes on. I have to go to a conference today. I better put some clothes on, right? Because it would be a little awkward if I didn't. So you put a shirt on. When you put that shirt on, you now can perceive it. Now I have a shirt on. I didn't before, right? But do you want your nervous system telling you all day, you have a shirt on, you have a shirt on, you have a shirt on? By the way, you have a shirt on, right? It's useless information at that point. We need to get on with our day, right? So this is the way in which the nervous system, and at least one of the ways, that it kind of triages and it compartmentalizes information so that you're not overwhelmed by sensory overload. Well, failure of the descending antinociceptive system, and nociception is pain, right, is one of the major things that is being investigated heavily in fibromyalgia and global pain syndromes, but it certainly is playing a role in chronic regional pain syndromes as well. Is failure of the DANs, as we call it, one of the major things responsible for some of these pain syndromes? So the bigger question is, what controls the DANs? What makes it go wrong? And it's interesting that there's a deep center of the brain known as the limbic system. And in medical school, we learn that as the emotional brain, right? It kind of controls our behavior, and it does a lot of things, but one of the things is it controls our behavior so that we do things that are not considered bizarre, right? Socially acceptable, things like that. When they look, for instance, at really warped people, serial killers and things like that, they have massive dysfunction in the limbic system. That's the biggest place where their brain is different. But now I'm talking, significant differences. But we can have changes that occur in the limbic system based on our experiences that can actually modulate the way we interface with our world, with all of our experiences. And the limbic system actually can control the descending antinociceptive system by way of the hypothalamus. And one of the main neurotransmitters that it uses as its messenger is called serotonin, or 5-HT. So we're going to talk a little bit about the limbic system and how serotonin plays a role and how we leverage that clinically to try to help patients with various chronic pain syndromes. We know if there's limbic system dysfunction, or if there's limbic system lesions, there's ischemic lesions, or there's mass effects, or something like that, you get a lot of different things that start appearing, certainly in global pain syndromes and other chronic pain syndromes as well. Things like hypervigilance, sleep disorder, anxiety, irritable everything, right? Irritable bowel, failure of the descending antinociceptive system, increased skeletal muscle tone, increased activation of your stress response. You become sympathetic dominant. You become in a sort of perpetual fight or flight kind of scenario. So limbic system dysfunction can be the answer for a lot of what's going wrong in these central pain processing disorders. And what's very interesting, and this is not this does not happen in every single case. It's not part of every case's history, but we do know in global pain syndromes like fibromyalgia, there's a significantly higher incidence of difficult upbringings while the nervous system was maturing and learning to deal with the world. When it was very neuroplastic, there's a much higher incidence of things like stress in childhood, conflict with parents, divorce, while acrimonious divorces, for instance, in parents of children who go on to develop these disorders, and certainly verbal abuse, physical abuse, sexual abuse is probably the most express train to some of these disorders, like fibromyalgia and irritable bowel syndrome. So it appears that if you're activating these alarm pathways, these very sympathetic dominant stress pathways early in life, you almost set in a pattern where then later on stressors, and they could be, the later on stressors could be traumatic physical stressors, they could be emotional, they can be all kinds of different things, can actually get you back into this pattern to a point where you express with a clinical disorder. So adverse childhood events or things, they call them multiple different things now. There's lots of researchers that are tying these things to higher incidence of different disorders, including chronic pain disorders. And parallel to that, you have a much greater understanding of different types of pain. I mean, when we learned about pain back in medical school, or in my case first in chiropractic school, you learn about nociceptive pain. That's the easy one. That's kind of the model I was showing you. You know, if someone sticks a pin in you, or you get some kind of trauma or something like that, then we know how that wiring works and how those pain systems work. Neuropathic pain, this happens when you have some metabolic reason or some change to the actual nervous tissue itself, such as diabetic neuropathies, small fiber polyneuropathies, things such as that. But there's more than these types of pain. There is what they're now calling in the literature third pain. And because it's a third type of pain, a pain that most physicians don't really understand, they're not comfortable with, and they don't think about. And that is deep-seated pain that's coming from pain perceptual problems really deep in the brain. And a lot of this is tied to early life experience, adverse childhood events, or early life trauma or stress. Particularly if there's situations where you felt unsafe, threatened, or somehow not in control. And they're developing what are called neurosignatures for global pain syndromes, chronic regional pain syndrome, a lot of these other things that have this third type of pain. So now with functional MRI and other types of imaging, we can actually go after finding objective ways to diagnose and quantify these types of disorders. And most of my familiarity, I will admit, is more in fibromyalgia and global pain syndromes. But we're now developing objective markers for fibromyalgia for the first time, but they're not blood tests. Right? They're really more imaging of what's going on functionally in the brain, combined with specific patterns on sleep studies, which I'll show you in a minute. Now, many people mention low-dose naltrexone. Low-dose naltrexone has been very helpful in my practice with global pain patients, and it was often, questioned, why is that? I mean, it's being used in so many things now, from autoimmune disorders, MS, weight loss. I see it being used. It's used, it's the latest, greatest thing. But in chronic pain syndromes, it really does have clinical utility. Now, not based on its normal mechanism of action, which the drug at full dose is a blockade agent of neuronal opioid receptors. It's used in addiction medicine and so forth. That does not seem to be the way it's working in low-dose administration in many of these disorders, particularly in inflammatory disorders like autoimmune conditions. It appears that low-dose naltrexone is really acting through what's called a pleomorphic effect. It has the ability to squash microinflammation very, very deep in tissues. So does statin medication, so does vitamin D, for instance. They're all pleiotropic agents, and many times we're finding out that those agents that we thought worked for some other mechanism are actually working through these mechanisms. And if you look at some fairly recent evidence, out of Massachusetts General Hospital and Harvard, they're showing, and someone mentioned before, this microglial activation deep in the brain. So low-dose naltrexone may be working on this sort of mechanism. It's interesting, something like fibromyalgia. If you ask most doctors, what is fibromyalgia? They'll say it's a muscle problem. And I'll say, no, it's not. Yes, it is. They have pain in the muscles. Well, they have pain, perceived pain, in all the soft compliant tissues, not just the muscles. But if it was a muscle, I tell them, what muscle disorder do you know that can cause irritable bowel syndrome, anxiety, depression, unrefreshed sleep, right? I go on and on and on. That's a centrally mediated problem. That's much bigger than a muscle problem. If you ask them, is it inflammatory? They say yes. Even though we know fibromyalgia subjects, they don't have all the normal global markers of systemic inflammation. They don't have SED rates that are high. They don't have C-reactive protein that is high. So it's really not an overtly inflammatory disorder. But we do see this microinflammation deep in the brain. That really throws physicians off their balance a little bit, because when they think of pain, what do they immediately think of? Inflammation. They think tissue trauma, tissue insult, inflammation, and that's not really what's mediating this type of pain. So some of these agents that can go out after really deep pain are very, very useful. The other thing we need to look at, though, is sleep. And I know Jim's standing, so he's pushing me off. We really pay attention to people's sleep and making sure they get into deep stage 3 and 4 sleep where they get restoration. Alpha wave intrusion is this specific type of sleep dysfunction we see in chronic pain patients. So we work with them with blocking blue light apps to get them off their electronics at night, block the blue light if they need to be on them, use of amber lenses. For instance, I'm not sure, but I pretty much think Bono has no chronic pain syndrome, but not sure. We use light fixtures with blue deficient light. We know that increases melatonin at night. It increases sleep quality. We pay attention to sleep hygiene. We use light boxes. And we combine this with having we need to calm down that central nervous system overactivation. We do it with various forms of biofeedback, heart rate variability, different things to actually retrain the brain to get into less of a sympathetic dominant, sort of what we call a hypervigilant state, because that will perpetuate the pain response. We do look at serotonin as a main chemical mediator of the pain, because as serotonin goes down, which we see in chronic pain patients, this substance P I mentioned before goes up. All those association neurons light up, and you can have this widening of the fields of pain and failure of the dance. So we do use agents to modulate serotonin, although we don't go right to SSNRIs or SSRIs or depression medications. Sometimes we do use those, but we tend to favor things like serotonin precursors, like 5-hydroxytryptophan. We use melatonin to help sleep. These are all on the serotonergic biochemical pathway. But we use a lot of other neurocalming natural agents, GABA, L-theanine, inositol, calming adaptogenic herbs. There's lots of medical literature on 5-HTP head-to-head against various classes of antidepressants. We monitor these levels with organic acid testing or in blood tests. So we follow the patients, and we tend not to use botanical agents that interfere with the drugs or the clearance of drugs or other things people are on. So we stay away from, for instance, St. John's wort. We'll use things like crocus, we'll use scaledium. These are herbs that have mechanisms of action that are beneficial, don't interact with the drugs. Vitamin D is very important in pain modulation. I don't have time to get into that. We do look at the stress response very, very closely. We look at the catecholamines and the adrenalins and the different kind of mediators of this hyper-responsive state. This is the same kind of pattern, by the way, we see in post-traumatic stress disorder. And we're trying to get the patient out of this sustained fight-or-flight state. These are some of the natural agents we use. There are different botanicals or herbal medicines that are standardized to certain actives that we know are central nervous system calming agents. They're very, very useful. They don't tend to drug you out as much or sedate you or make you hypnotic, sort of like some of the parallel or analogous prescriptive agents. And then we use various types of modalities in physical medicine as it's appropriate. But the thing I'll end on is in functional medicine, we're not just looking at your diagnosis and then what is the one agent to treat you, you know, the mono-agent type of thing. We're looking at all of the different things contributing to your central and peripheral nociceptive sensitization and work around all of this with you as an individual trying to lower, basically take straw off the camel's back, right? Take some of the load off so that we can return, you know, your nervous system to proper functioning and return your neuronal sort of healing ability and mitochondrial function and other types of things, so that the interaction between the health provider and the patient is not this, but it becomes more this, right? And your existence becomes more of what you want it to be. Who won the World Series in 1996? Who knows? Anybody know? Who said Yankees? All right, you get a signed copy of the Fibro thing. I couldn't think of anything else to ask, but let me just tell you one thing. If anyone asks you who won the World Series in any year, statistically, the best answer is Yankees, okay? And then finally, I just wanted to say that we do have a table outside for the UB clinics. At the University of Bridgeport in our Health Science Center, we see about 25,000 patients a year in there in the UB clinics, and we offer a lot of different services for people with chronic pain syndrome. We have full naturopathic medical clinic, but also acupuncture, traditional Chinese medicine, chiropractic, and many other things that can be very helpful. So I encourage you to take a look at that as a resource if need be. Thank you.